Hello friends, today we are going to study about cancer of the rectum and it is chapter number 41. Information concerning epidemiology system approaches to the management of both colon and rectal cancer was given in chapter 40, and now in this chapter we will focus on the rectal cancer with the emphasis on the radiation and combined modality therapy and what is sphincter preserving surgery. So if we look into anatomy of the rectum. So anatomy of the rectum is quite confusing as there are different definitions of the relevant landmarks, and in the upper portion of the rectum there are changes both in the musculature of the large bowel and in the relationship to the peritoneal covering that roughly coincides. So in this lower portion of the rectum, the mucosal changes occur at roughly the same location as the anal sphincter. So anatomy of the rectum is usually divided into three portions. The lower rectum is the area approximately 3 to 6 centimeter from the anal verge. The mid rectum goes from 5 to 6 centimeter to 8 to 10 centimeter, and upper rectum extend from 8 to 10 to 15 centimeters. So upper is 10 to 15 centimeter, mid is around 5 to 10 centimeter, and lower is 3 to 6 centimeter from the anal verge. And although the retroperitoneum portion of the large bowel often reaches its upper limit approximately 12 centimeter from the anal verge, and in some patients, especially elderly women, the peritonealized portion of the large bowel can be located much lower than this definitions, and the determination of the location of the boundary between the rectum and sigmoid colon is important in defining the adjuvants. So why it is important to define the margin of the rectum and sigmoid? So that is for adjuvant. So externally, the upper extent of the rectum can be identified where the tinea spread to form the longitudinal coat of the muscle, and the upper third of the rectum is surrounded by peritoneum on its anterior and lateral surface but is retroperitoneal posteriorly. So rectum is surrounded, upper rectum is surrounded anteriorly and laterally by peritoneum, and posteriorly it is retroperitoneal without any serosal covering. So at the rectovesical and or rectouterine pouch, the rectum becomes completely extra or retroperitoneal, and the rectum follows the curve of the sacrum and its lower third and enters the anal canal at the level of the levator ani, and the anorectal ring at the level of the puborectalis sling portion at the levator of the levator muscles. The rectum follows the curve of the sacrum. So here we can see this is the rectum, this is upper hals of the Houston, the middle right middle valves of the Houston, this is peritoneum, ampulla of the rectum, lower rectum, 2 centimeter is the anal canal, and then lower, mid and upper rectum. So the anorectal ring is at the level of the puborectalis sling portion of the levator muscle, and the location of the rectum is most commonly indicated by the distance between the anal verge, dentate line, that is pectinate or mucocutaneous line, and anorectal ring and the lower edge of the tumor. And these points of reference are different for different individuals. In addition, these measurements differ depending on the method of measurement. This can be important clinically as the measurement from the flexible endoscope can substantially overestimate the distance to the tumor from the anal verge or other landmarks, and the distance from the anal sphincter musculature is clinically more important than the distance from the anal verge, as it has implications for the ability to perform sphincter sparing surgery. And the lack of peritoneal covering over most of the rectum is a major reason for high risk of local failure after primary surgical management of rectal cancer compared to colon cancer. The mesorectum is usually used as a structure to define the extent of total mesorectal excision, with most of the perirectal fatty tissue and perirectal lymph nodes contained within these boundaries. What is lymphatic drainage of the rectum? Lymphatic drainage of the rectum follows the course of the superior hemorrhoidal artery towards the inferior mesenteric artery, and the lymph nodes that are above the mid rectum therefore drain along the superior hemorrhoidal artery that are often part of the mesentery, and that is removed during resection of the intraperitoneal portion of the colon. Lesions that arise in the rectum below approximately 6 cm are in a region of the rectum that is drained by the lymphatics that follow the middle hemorrhoidal artery, and the nodes involved in the cancer in this region include the internal iliac nodes and the nodes of the obturator fossa. These regions deserve particular attention during the resection and irradiation of the lesion in this location, and when the lesion occurs below the intet line, lymphatic drainage occurs via inguinal nodes and external iliac chain, and which has major therapeutic implications, especially for the radiation field. The corollary of this high risk of inguinal node involvement for the very low lying tumor is that tumor located above the intet line are at a lower risk of inguinal node involvement, and these nodes are as well as the external nodes do not need to be treated, and these nodes as well as external iliacs do not need to be treated. So bowel function. Fecal continence is maintained through function of both the sphincter mechanism and the preservation of the normal pelvic floor musculature, which creates a neo-rectal angle or rectal sling. And the pelvic floor is composed of levator ani muscle, which separate the pelvis from perineum and ischial-rectal fossa. The urethra, vagina, anus pass through the levator muscle. Preservation of the fecal continence during surgery for rectal cancer is therefore dependent on a thorough understanding of the anatomic relationship of the musculature and the sphincter mechanism. Maintenance of sphincter apparatus without preservation of the muscular angle will have the desired results, and these anatomical constraints, especially with respect to lateral margin, make the use of adjuvant chemo and radiation therapy critical to a successful surgical outcome. And this is true from both the oncological and bowel function perspective. Now we'll see autonomic nerves. The preservation of both the bladder and sexual function depends on the surgeon understanding of the anatomic nerve supply to the pelvic floor. And the hypogastric plexus is formed from the sympathetic trunk as they converge over the sacral promontory, and the sympathetic nerves are found beneath the pelvic peritoneum along the lateral so they are found beneath the this peritoneum and along the lateral side pelvic side walls lateral to the mesorectum, and the second, third and fourth S2, S3, S4 sacral nerve roots, they give rise to parasympathetic fibers to the pelvic viscera, and the parasympathetic fibers proceed laterally as the nervi erigentis to join sympathetic fibers at the site of pelvic plexus, and that is just lateral and somewhat anterior to the tips of the seminal vesicle in men. And to preserve this structure, therefore sexual and bladder function, sharp rather than blunt dissection technique should be used to dissect the mesorectum. Thank you.